Hello, my name is Dr. Christopher Ninh. I'm a board-certified fellowship-trained sports medicine doctor. I specialize in minimally invasive total joint surgery as well as arthroscopic surgery. First I'd like to talk about is the direct anterior hip total hip replacement. What it is, it's an incision that you go through the front, and it's a muscle splitting procedure. You don't cut any muscles. You preserve the big muscles of the hip, the abductor muscles, as well as the posterior gluteus muscles and external rotators. The interval is very good because it allows us to do surgeries on larger patients without much dissection. There's less blood loss. Patients are able to recover and rehab faster. They're able to get up the same day, walked. The surgery is done under fluoroscopy, that means under x-ray vision, so we're able to get the components in perfect position where we want it to be. The hip now was able to be done fairly recent because of the advent of new technology. Most total hip replacement surgeries were done posteriorly. That means they were cut on the back, and muscles were cut, there's more blood loss, bigger dissection. It was done so because the implants we were using, we had to use and go through that route. With the newer implants and the new special table, it's called a HANA table. It's basically a traction table that uses hydraulics and hooks in order to position and manipulate the leg in order for us to introduce these smaller and better implants through this approach. And this was only in the last maybe 5 to 10 years that we were able to do it and do it well. I've done posterior hip approach in the last 10 years. In the last year or so, I've completely converted over to the direct anterior hip approach because my patients are doing a lot better. They're rehabbing quicker. Literally within 2 weeks, they're not using any assistive device. They're driving. 2-3 months out, they're surfing, going back to normal activities, golfing, dancing, and it allows us really to get the patient back to their lifestyle, essentially giving back their life. The biggest, I think, motivating factor for me is to do a surgery in which patients basically say after full recovery, I don't remember I had a hip surgery. I don't even know which side I had it. It's so natural that they're basically saying, it feels like I didn't even have surgery. And that's really the goal. The newer implants we use now are, they have different surfaces, ceramic, oxynium, in which they're a lot smoother. They last a lot longer, 20, 30 years even. We use special components, which I use called MDM, which basically is the ball within a ball, so the range of motion is better. Essentially, when you do this direct anterior hip approach, the likelihood of dislocating posteriorly is very little to nil because none of the posterior structures are compromised at all. And so therefore you don't really dislocate because there's no compromise and there's no dissection that really causes like a hole or a gapping or scar tissue in the back. Now also with, like I said before, under fluoroscopy, the implants are put in positions that are ideal. So you don't have the problems of misplacing, malpositioning components. Before, for example, patients with large hips, where we had to dissect a lot, it was very difficult to place implants in proper ideal positions because of their habitus, their structure. And so with the direct anterior hip approach, we're able to manipulate and maneuver in such a way that there's really no barriers to putting those implants in good position. And patients literally come out of the surgery, perfect leg length, very balanced, great position, and minimal blood loss. I think this is the real deal. And I'm proud to say I've spent a lot of training in it, training with the gurus of it, and I'm able to utilize this technique to better my patients in the last year, and we're finding remarkable results. The next subject I'd like to talk about is a total knee replacement. I do a minimally invasive total knee replacement. Basically, I do a small incision, approximately 6 inch. I do a muscle splitting approach, and I also do a quadricep splitting. I basically use a single one tray system. Essentially, they're plastic. They're plastic trials in which were more sterile. I use a double block, which is a spinal and a local block. And what it is basically it allows patient to have a better, speedier recovery. They're breathing on their own. They're not under general anesthesia. My surgery lasts 45 minutes, so it's fast and it's efficient. It allows for minimal blood loss. I'm one of the biggest Jehovah's Witness total knee replacement surgeon because of our less blood loss or bloodless type of surgery. I use a reinfusible drain, which the drain pulls the blood out of the knee, filters it, gives it back to the patient. So it allows us to really preserve the blood. Now I also use what's called Vita gel. We take blood, we use the coagulant constituents, and we inject the knee, and so again it prevents blood loss, helps to coagulate the knee. I also use what's called aquamantis. It's basically a device that cauterizes or burns the knee. It's kind of like a water laser in which it prevents bleeding into the knee. And then when we close the knee, we use reabsorbable sutures and dermabond tape. It's essentially a tape device used in plastic surgery and allows better healing, waterproof, and there's no staples, no railroad tracks, no scarring. And because of these techniques we're able to use, we get less blood loss, better recovery, faster recovery, and patient scar looks great, and people up and out of the hospital within 2 days, up and walking within 1 day, and patients do great. 3 months full recovery. Patients are able to essentially get back to their normal lifestyle before their disease. Knee surgery, the incidence now and prevalence, we're getting to 700 to 800,000 a year. And that number is going to double in the next 5 years. So with these newer techniques, it allows patients to rehab faster and do better. We have now the gamut in terms of the range of patients now are widening because patients are not waiting for the surgery anymore. They want to be active. With newer implants, we have again the Oxinium knee. It's basically a ceramic coated knee. We have the golden knee, Escalap's coated knee. This slicker surface allows less wear. We have a plastic that's cross-linked polyethylene. Essentially, it's a cross-linked poly, and that lasts a lot longer, and it basically gives the knee year up to 30 years, even longer of lifetime. So patients now are opting having surgery earlier to maintain or actually improve their life. Patients that are older are having these surgeries because we can use these anesthesia, pain control, special blocks, and reinfusible drains and blood preservation techniques for patients to have a healthier and a less stressful surgery. And that's the newer, innovative total knee replacements that we do, and we're getting remarkable results. So I am a sports medicine fellowship trained orthopedic surgeon. I do arthroscopic minimally invasive shoulder and knee surgery. One of the biggest shoulder surgeries I do is rotator cuff surgeries. Now, rotator cuff tears are very prevalent. The rotator cuff is a band of muscles, forearm muscle, that helps you raise your arm and turn it inside and outside your arm. Now, over 80% of patients over 60 to 70 have rotator cuff tears. And what I do is minimally invasive techniques in which I use little portals, little holes smaller than my fingernail, a centimeter, with a camera. It allows me to go in there deep, reattach the rotator cuff, remove any bone spurs, and do this all minimally invasive. Patients go home the same day. Surgery is about 1 hour long. The whole idea is really preserve the rotator cuff function, prevent any further tearing, because when there's more tearing, the rotator cuff gets atrophy and dies, becomes fat, and actually you get what's called pseudoparalysis. And that's what we want to prevent. Patients are living longer now. They need their shoulder function. They have bone spurs and they have tears that with time it's mostly degenerate, and we're able to fix that, and the earlier the better, to help preserve that function in the shoulder. And we do that here, and again, we do a great job. Now, the last subject I'd like to talk about is the knee arthroscopy, and specifically anterior cruciate ligament reconstruction. I'm a sports medicine fellowship trained doctor. I specialize in that. Now, one of the biggest injuries for young adults is anterior cruciate ligament tears. Okay, and this is usually a traumatic event, usually a running, a twisting event. They would feel a pop and it's swelling their knee. Most of it is non-contact. 70% of this surgery, 70% of the injury is a non-contact type of impact. Now, over 150,000 cases per year is surgery to perform to reconstruct the anterior cruciate ligament. Literally, the patients that have these tears are unable to run, unable to dance, unable to do any type of activities that involves pivoting, twisting, turning. Okay, they would get giving away episodes in which then they would get arthritis, or prone to more arthritis, prone to other injury of the meniscus because the knee is unstable. Now, the anterior cruciate ligament reconstruction is very tricky. I consider it like an art, because anybody can put a graft through, but the thing is you have to put it in a position, orientation that mimics the knee. Everyone's knee is different. Everyone's knee has different laxities. Some people's knees are tighter than others. Different people have different anatomies. In order to basically place it in a certain position to allow them to be tight and stable, yet allow to bend and straight fully the range of motion, is a very tricky art. It really requires a specialized sports medicine trained that does many. I do many of these. I do about 15 to 20 a month of these surgeries. And so we do everything minimally invasive, arthroscopic. I use patella tendon bone autograft because it's bone-on-bone healing, allows for faster healing, more consistent. And this is what most professional athletes and dancers get, and that is what I use. I only use the best. And I feel that it really takes a good trained fellowship orthopedic surgeon that does many to be able to do it well. And that's what we do here, and we get you back on the field.